Good morning, everyone. I am Dr. Manjunath, Professor and Head of the Department Pathology, BGS GIMS. Today, I'll be highlighting about the errors in laboratory. First of all, I thank LACNAR Health Professional Placement App for giving an opportunity for conducting this talk. So, I will lay out our errors in laboratory in four phases. First one is what are the errors in laboratory. Second one is why errors occurs. And the third one is types of errors and how to prevent errors. What are errors? What do you know by errors? That means it's a difference between the true result and the measured result. True results means it may be an accepted result. So failure of planned action to be completed on can occur at any part of the laboratory cycles, from ordering the examination to the reporting the results and appropriately interpreting and reacting to the result data. The handling of samples is critical in decreasing the errors in the laboratory results. That is the main theme of avoiding the errors in laboratory. Then what are the various frequency of laboratory errors varies greatly depending upon. One is it mainly depends upon the study design. Secondly, the specific steps of total testing processes, that is known as TTP, investigated. So the why do the laboratory error occurs? First and foremost is it may be a understaffed or an untrained, means they may be qualified but they are not trained for the particular machine or particular investigation. Second one is inadequate attention to the details. Inadequate attention to the details means they may not be seeing the whatever the prescription that has been written by the clinician. Third thing is poor sample control. Poor sample control means whether the sample is sent in the proper collection tube or not, because if the serum investigations, if they have sent only the EDTA tubes, that means plasma tubes, that means the errors may occur and it may reflect on the management of the patient. Then the third one is poor result verification, then quality control and assessment, then non-validated test. Non-validated means validation usually conducted by the manufacturing bend. Only thing is verification will be done by the clinician, by the laboratory personnel. Then the true pressures means pressures depending upon by the management or by the patient himself regarding we want early report like that, and poor workload management. This is the study design why these are the places where the laboratory errors can happen. Then possible source of laboratory errors, that means various factors leading to laboratory errors of patient tests. One is first and foremost is specimen collection. Collection is an important place where most of the thing, 80% of the errors may occur there. Second one is specimen handling. Handling of the specimen, especially the handling of the specimen in histopathology, because they have to know whether it has been sent in the proper fixatives like formalin, for example, and properly labeled. Then third one is chemical analysis. Chemical analysis, it depends upon the instrument performance. It may be in the form of regular instrument maintenance, quality assurance program, which we have done the quality assurance program to gain the proper results. Then the fourth one is patient preparation. How the patient is prepared. See, we will ask mainly what are the samples that should be taken for the empty stomach, and minimally it should be between the 12 hours gap following the last meal. That is the patient preparation. Then reporting the results. Reporting the results also very important, because we have to give a proper result test report, then the proper reference for the age and sex of the patient. Then coming to the classification of lab errors. Classification means how this classification, the various steps, that errors of steps can be differentiated. First and foremost thing is latent error. That means these are the errors occurring due to, first one is organizational failure. That means example, one is low or understaff recruitment. Then second one is multitasking is and improper job description among the staff. That means overloading the technical staff for the duty, and the lack of instrument interference. That means interference lack means, that means the report that has to be transferred to the computer data. That if that is not there, if they have to type manually, there is a lot of typographical error, especially in the numerical typograph. Then poor formatting of results. That means we have to format the results depending upon the age and sex. Then overloading of analyzer and no backup. That means overloading means continuously running the instrument, and in between there is a norm for the instrument to check the quality assurance program after certain sample size. That is the instrumentation overload. Whenever it breaks down occurs, if there is no backup, that will hamper your turnaround time of the report that will be given to the patient. Second thing is infrastructure and design. That means poor laboratory layout leading to the misplacement of specimen. That means there should be a proper area for a particular machine and a sample to be tested for that machine only. That is the important one. And poor sample labeling policy. Nowadays barcode has come, but the earlier days we used to write, or we used to print the name and we used to stick onto the tubes. But now the barcode has come, but with the barcode also sometimes the two different same names may, and almost a nearing age also may lead on to errors. Then policy, design and process pertaining to the test requisition forms. Test requisition forms you have to read carefully, and nowadays it is because of barcode, everything will come in the system, but we have to read carefully, and then we have to start the performing the instrumental handling of the instrument with sample. Then third one is faulty policies and from the management. That means pure communication between the staff and departments. Means whenever the staff finishes his duty, handing over, taking over, whether left out sample has to be told and the critical alerts to be told, and if there is a reported for a repeat sample, that has to be conveyed, and the proper communication to the departments for the repeat, for the legibility of the this one, what is that, whatever the prescription, lab prescription that has given, or sometimes a communication to a critical lab result communication to the department. Then excessive focus on management on cost. Cost wise, if you want to cut down cost, management can say please cut down the cost by not repeating. Sometimes we may have to repeat because we don't know, sometimes because of if there is one instrument and there is no the backup machine is overloaded. That means it may skip one sample and take the another sample. Sometimes what happens, the previous sample data may be merged with the present sample data, that may give a erroneous numerical data. That may be the one. Then management's approach towards the incident reporting. Incident report has to be properly managed by the management. Then what is the second one is, first one is the latent error, second one is the active error. What are the active errors which can take? The rest are active errors, which are often three types. One is pre-analytical, analytical and post-analytical. Nowadays it has been modified to 5 types. One is pre-analytical, pre-analytical, analytical, post-analytical and post-analytical. What happens in the pre-analytical? Pre-analytical is from the time the clinician gives the prescription with a proper name, proper age. Then it goes to the billing section. Then billing section will do the proper name, and if the two patient comes with the same name, the barcode should be different and the age factor should be noted, and even the address to be maintained, and the proper person or a clinician who has written for that investigation. That is pre. Then the pre-analytical. Pre-analytical, what happens? What are the pre-analytical methods? That causes usually pre-analytical accounts for about 42 to 43% of the total error. Then analytical point where the maximum usually analytical part will take place, and the post analytical is the least one, which accounts for about 24.3, and analytical, which accounts for 32.5%. Then post analytical phase, what happens? Pre analytical phase, mainly it depends upon the usually the what the prescription from the prescription to the billing section till the barcode happens. Then the pre analytical, after the billing session, it will be properly documentation and proper collection of sample with a proper tube selection and a proper instruction to the patient what is the mode of collection. Then the analytical phase, whether the test is validated by the manufacturer, or here regular authentication of the test results, mainly whether the morning delta check has been done, startup has been done, or the quality control assurance program is in place. Is there any outliers in the quality control program? And then the post analytical, whether the interface of the result which are into the computer has taken place or not, whether there is any technical error. Then post analytically we have to see again whether that barcode is matching with that of the data which is sent by the instrument. Then post analytical, while handing over, don't see the results, don't see the name. It should be based on the barcode and verification of the name and verification of the address. That will help in mainly giving the same report, one report, the Ramesh or Namesh with the same age, 45 or 46, thinking that the barcodes may be same and the two Ramesh may be interchanged. That will lead on to a erroneous management at the clinician side. That is the post analytical. That pre-analytical, I have already told, the most reaches the lab. That pre-analytical initial steps of specimen undergoes before it reaches the laboratory. That means improper test request and improper billing, order of entry mistakes, then patient sample misidentification, then sample collection, whether it is hemolysis where it might have happened, clotting might have happened, especially that happens at the bedside collection of samples, or fluid or the volume overload, because the tubes have been mainly designed for certain volume only, because whatever the preservatives that it applies for only to that specific ml only. Then improper container, then sample handling and storage and transport problem. These are the pre-analytical. Then the pre-analytical usually pre and post errors are estimated to constitute about 90% of the errors. Errors at any stage of collection, testing and reporting process has potentially led to a serious patient mismanagement or misdiagnosis. Errors during the collection process are not inevitable, but can be prevented with a diligent application of quality control, continuing a medical education, then effective collection system. These are the important in pre-analytical. And what are the steps that can prevent the pre-analytical phase? Preparation prior to the pre-analytical phase, sample handling and storage and transport, and preparation prior to the analysis of the patient sample. In the implications of errors, errors can be made in the period prior to the analysis of the sample, may influence the quality of the final measured results, and compromise the diagnosis and treatment of the patient. Then what are the pre-analytical other errors, which includes labeling errors, shorting and routing of errors, and pour of errors, then specimen processing errors, that may be centrifugation and auto decapping and aliquoting errors. Then steps in pre-analytical errors, patient identification, sampling technique and collection procedures, which happens outside the lab, whereas the specimen processing which happens inside the lab. Then preventive actions, what all preventive actions can be taken place in pre-analytical phase. That means the phlebotomist should be educated properly and it should be frequent. And every month there should be a periodical assessment and the education. Then academic course and training under supervision of senior phlebotomist and continued medical education. Competency assessment has to be taken, and professional licensure and phlebotomy staffing, then adequate staffing to maintain collection standards, technology, and use of barcode scanner for patient identification. Then analytical errors, it may be systemic errors which indicates poor accuracy, or random errors which indicates poor precision. Accuracy which may lead occurs as a result of poor calibration, wrong standards, incorrect procedure. Whereas deviation in the poor precision may be due to pipetting error, transcription error, incorrect sample numbering, and reader fluctuation. Then how to prevent? There should be a regular maintenance of the instrument. That means you have to check for the calibration periodically, whether it is 6 months calibration or yearly calibration, and the sample processing, whether the startup is passed and quality assurance program in place. Then you have to do a duplicating. Then you have to do a protocol assessed programming of the instrument. That means daily there should be a checklist. Regular staff training and competency assessment has to be done. Then please adhere to the internal quality assurance program, external quality assurance program, proficiency testing, and interlaboratory quality assurance program, which is done at the various centers outside the lab premises. Then practical approach to experience sharing to prevent analytical error. One is sample, reference intervals to be in place, personal and quality system validation should happen, equipment and automation has to be checked, method of analysis has to be checked, and reagent status has to be checked. And the post-analytical error. What are the post-analytical error? It is a phase of total laboratory testing process, inappropriate use of laboratory test results, critical results reporting, and transmission correct results are areas of potential errors. We can avoid by standardizing the procedures, training and education. Computerized critical results reporting has to be done. Then how to monitor? Next, how to monitor the errors? Mainly to success of any efforts made to reduce the errors must be monitored in order to assess the efficacy of the measures which are taken. Then quality indicators must be used for assessment tool. The entire healthcare system must be involved in improving the total testing process. There must be an adequate, effective training of personnel throughout the institution to be competent in the following process. Importance of lab errors. It mainly more accurate to helps it in the more accurate results, less hazards and error prevention, patient safety, more qualified diagnostic techniques. Then post analytical errors. What can happen? It may be a misplacement of the lab reports, delayed turnover, data entry errors, and data transmission errors. These are the post. The take-home message is it's mandatory for the laboratories to run internal and external quality assurance program, identify and minimize the errors occurring in total testing process, that is TTP. The best laboratory practice can be achieved by regular interaction between the clinician and the laboratory and the pre-analytical, analytical, post-analytical phase of total testing processes. So the main importance here, it is a chain of reaction from the clinician from his prescription, ordering the order, then the staff who are involved in billing, and the third thing is person who was involved in the collection of the sample, and the fourth one is within the laboratory receiving the sample in a proper manner with a proper understanding what the clinician has written. So after that analytical, and the post-analytical, where the delivery of results to the patient and the patient takes that result to the clinician. With the clinician assessment, with the clinical and the laboratory data, he will come for a management. Final management will happen. So it is a bonding between the clinician, a laboratory medicine, and a patient management. That's why all our doctors who are involved here and clinicians should be well versed that the laboratory medicine and personnels also, they are the medical personnels. Whenever they give the any critical alerts, it has to be taken care immediately and it has to be reflected into the management system. That means patient management system helps in the patient well care of the patient well-being. So I request everyone to be in the chain with the clinician support and the laboratory support, for we both are doing for the patient management. Ultimate goal of our patient is to patient should be disease free and he should go happily from the hospital or from the OPD sector. So this is my take home message. We are all in one roof and we are doing it for the patient care. That is the main aim of our doctor professional, whether it is clinicians, whether it is laboratory doctors, or whether it is technicians who are involved. They all aim for the patient safety and patient management and patient well-being in the laboratory areas as well as in the hospital areas as well as in the OPD areas. This is my opinion regarding reducing the errors in laboratory. So I thank once again Lagnar Health Professional Placement of App for giving me an opportunity to highlight my views in patient management in the hospital setup as well as in the OPD setup as well as in the diagnostic setup. Thank you. Thank you all.